All right. So welcome to the final Community Behavioral Health Information Technology Coalition session. My name is John Glover, and I'm a project specialist for Metastar. Just want to remind you that if you're comfortable, please use your camera. We'd love to see you if that's okay with you. And do remember to mute yourself when you're not speaking, and don't forget to unmute yourself when you want to ask a question. Let's look at the agenda for today. Quickly, we'll just have some quick announcements. We'll do our introductions as usual, and then we'll have a topic presentation. We're very fortunate today to have Dr. Jonathan Neufeld, Program Director at the Great Plains Telehealth and Resource Center located at the University of Minnesota. Really excited about having that connection for you all and having him talk to us a little bit today about hybrid telehealth and who to provide it to and when, sort of looking into the future a little bit. So after his presentation, we definitely want to have some question and answer and discussion. I think Dr. Neufeld is very interested to hear from you as well in terms of what are your challenges and interests, because his organization is very interested in trying to help us to solve those issues and provide support. And then at the end, of course, we'll provide you with a few additional resources, and you will get notes after the session with the slides, etc. All right, so in terms of announcements, just want to remind you, we've been trying to let everybody know, but our current grant will be ending on September 30th. So we're working with DHS and hoping that somewhere in the future we'll be able to continue to work with you. We know a lot of people have said how helpful this has been, but that we really have only scratched the surface in some ways. So that's a future to be determined yet, but the current grant will end on September 30th. And this, as I said, is our final CBHIC session. One other announcement is we have created a couple of e-learning modules, and we've tried to send the links out to you all. One is on information blocking, and the other is on 42 CFR Part 2. These are both on the Metastar website, and you can find them there, and you can walk through those modules. We're hoping that those are helpful to you, and we'll probably look at updating them if necessary, once SAMHSA comes out with additional clarifications about 42 CFR. So the other piece is that our Health IT Radio, Metastar Health IT Radio, we have two final podcasts that are currently getting produced. Two-part series on future trends in health IT. And our Metastar project specialists, Lori Mantefel and Jason Sushan, will be presenting on these topics. So keep an eye out on our podcast website, Health IT Radio, for those two podcasts. So you'll know kind of what to look for going forward, what kind of things are happening out there that you want to keep an eye on. All right, so those are available on www.metastar.com/podcast. So to move forward here, the group process here, this is not a webinar. However, we are changing up the format a little bit per your request. And Dr. Neufeld is going to provide some slides for us and a little bit of information. This is something the group expressed an interest in. But we do want to continue to focus on the discussion, the question and answer, and make sure that we are addressing the topics that you're concerned about and trying to find answers and support for you in those areas. So please join the conversation. We're all here to learn from each other. Feel free to ask questions. There is no stupid question to be asked, right? We're all trying to figure this out, and there's lots to do. All right, so next up is introductions. And I want to walk through here. Let me see. So let me start with, I'm going to start going down my participant list here. Andrea, would you just unmute yourself and tell us just who you are and what organization you're with, quick?
My name is Andrea Peterson. I am from the Guest House of Milwaukee.
Oh, great. Thanks for coming today. And let's see, and Claire?
Hi, I'm Dr. Claire Lewandowski, clinical psychologist here at Kenosha Community Health Center.
Thanks, Claire. All right, and then we got Fern.
Hi, I'm Fern Conitz. An individual and family therapist in the in-home program of Orion Family Services, as well as CQI manager.
Thanks, Fern. All right, and Nicole?
I'm Nicole Reeder, and I'm an outpatient counselor with Ozaukee County Department of Human Services.
Great, thanks for coming today, Nicole.
Yeah, absolutely.
All right, and then we have Ruth.
Hello, I'm Ruth Gilmore. I'm here for my supervisor, Alicia Carlson, who is head of behavioral counseling here at Sawyer County. She couldn't make it, unfortunately. So.
Okay, well, I'm sure you'll fill her in then, Ruth. Hopefully we have some good information for you today.
All right, thank you.
Yeah. All right, and then Samela.
Hi, I'm Samela. I'm Director of Clinical Services at the Guest House in Milwaukee.
Great, Samela. Thanks for bringing your team. And Shannon?
Hi, I'm Shannon Esla. I am with Behavioral Health Services of Memorial Medical Center in Ashland, Wisconsin. I am the Recovery Services Program Coordinator.
Great. Thanks for coming, Shannon. And Taryn?
Yeah, I'm Taryn Pratt. I'm the Health IT Tech for Unified Community Services in Grant and Iowa counties.
Great. Thanks, Taryn. Then we have Thomas.
Tom Trin with Department of Human Services for Ozaukee County, System Administrator.
Great. Thanks for being here again, Tom. All right, and then I see that Luis has joined us. Luis, you want to just quickly introduce yourself?
Sure, Luis Diaz with Waukesha County Health and Human Services.
Great, thanks for coming, Luis. All right, that is, I think I've grabbed everybody on my participant list. Is anyone that I didn't call, would you please unmute yourself and introduce yourself just quickly? All right, I think I might have got everybody. Imagine that. All right, so as I said, what we want to do today is start off with the presentation by Dr. Jonathan Neufeld. He's the program director at CBHIC, which is Great Plains Telehealth Resource and Assistance Center. It's a federally funded technical assistance center located at the University of Minnesota, and they provide support for 6 states in the Midwest region, and I'm sure he'll tell us a little bit more about that. We're really fortunate to have him today because it's Telehealth Awareness Week this week. And he's also provided us with a podcast previously, earlier in the year. And that's a great sort of introduction to some telehealth issues that if you're interested in looking or listening to that, it's about 10, 12 minutes or so. So really great to have him back. He's consulted on a wide range of projects related to rural health and telehealth over the past 15 years. He's presented at numerous regional and national conferences. He's published peer-reviewed articles in the fields of telemedicine, clinical decision supports, mental health services evaluation, and clinical outcomes. So again, as I said, we're really excited and happy that he was able to join us today, and look forward to his presentation and talking with him a little bit. So you all prepare your questions, and we'll see if we can't learn a little bit more about CBHIC and help him learn about us. Dr. Neufeld?
Great, thank you, John. All right, I am going to share my screen, and also greetings, everybody. Welcome. I guess I'm not, I shouldn't be welcoming you guys. You guys are welcoming me. I'm a guest here, but very honored to be able to come and talk to you. And I'm gonna charge into this and assume that you'll all wave your hands or shout at me if something isn't showing up, or if you've got audio or video issues, let us know in the chat. What I want to do today is I'm gonna keep my comments as brief as possible, point out a few things that I see coming down the road. I'll make a few comments about hybrid telehealth specifically, but really what I'm trying to do is just lay a little groundwork and then hear what you all are interested in, what you're struggling with. One of the things that we're getting asked now, we have several different kind of audiences. One is folks who are doing telehealth out in the field, but another is state level administrators and even some folks at the federal level who are saying to us, you know, what do people need? What are the questions out there? Where are the resources needed, or what are people struggling with? And so part of our job is to get information back to them about what's happening with telehealth out in the states and the rural areas wherever it's being used, which now is everywhere. And so I want to spend some time having you guys talk a bit about what your issues are, certainly asking questions and have a conversation like John said. I'll give you a little bit more information about me and the TRCs and GPTRAC in specific and who we are. And I have two main slides. One is the key considerations, the things that we hear all the time and the things that I tell people, hey, be thinking about this, be thinking about this. And the second one is a little more specifically about the future of telehealth policy, where we see it going. We don't have a crystal ball, and we're really not a policy shop per se, but we certainly see a lot of the conversation and get a sense of what's going on in the field. I have a couple of chunks of slides that are optional if we want to go into them. If somebody asks me in specific, we can go into stuff on workflows or clinical video skills, which I talk about a lot. And then we'll mention a little bit about this group possibly continuing and see where that goes. But a lot, like I say, those slides at the end are optional, and we can bounce through those. What I really want to do is hear more from you folks. So let me tell you just a little bit more about who we are if you don't know. The Telehealth Resource Centers are funded by HRSA, Health Resources and Services, which is a department within the federal HHS, Health and Human Services. HRSA is the safety net funder. So it funds community health centers. SAMHSA, sister division, funds mental health centers. And within HRSA is this little office called the Office for the Advancement of Telehealth. We were little for years and years. This year, all of a sudden, we got a big upgrade. Not we, but the department got a big upgrade, and it is now a special section of its own within HRSA. So there are 14 centers. Mine is that one in the middle and the top there. We're centered in Minneapolis, but then cover all the states around Minnesota as well, including Wisconsin. And what we do is provide a lot of this. Go to meetings, provide webinars, do talks, answer questions. The primary way that we can interact with you, though, is get in touch with us. Tell us what you need to know. If we don't have a resource on it, we will find out. And if we don't know, we'll find somebody who does know. That's what we're a clearinghouse, but a kind of a full service organization that we want to answer your questions and put you in touch with people that you need to be in touch with. So to the extent that that you can come up with things, questions and things that you need from us, let us know, and we can do that. We really do. We count every contact, and that's our main bread and butter. Most of these presentations are basically let people know that we exist so that they can contact us and ask their questions. So I'll cover a bunch of stuff, but one of the things we've learned, the main thing we've learned over the years, 10 years or more that the TRCs have been going on, is that telehealth is different things to different people. And so one set of answers just doesn't ever cover it. We have to be able to dig down into the weeds to really be of use to people. So here's my number one main slide, and the six areas things that I tell people going forward in telehealth. I'll go through these one at a time. Broadband, of course, is an issue. You don't need the best, but it's necessary. You got to have broadband. And if you're in an area that just doesn't have broadband, there is not a whole lot you can do about that. People ask me all the time, well, what if we don't have any broadband in our area? It's like, phone calls, that's all you got. And so, and that's one of the reasons why audio only was such a big deal in the pandemic, because everybody flipped to telehealth. And then we realized, hey, wait a second, not everybody has a smartphone. Not everybody has Wi-Fi at home. Yeah, they don't. So then we needed to use phones. So for video, obviously broadband, and it's the water your boat floats on. It doesn't matter how fancy your boat is. If you don't have any water, it doesn't go anywhere. We also are finding all kinds of stories, hearing all kinds of stories about ways that rural communities or places where either the patients or the community doesn't have a lot of access, cultivating alternative Wi-Fi hotspots. You know, we don't like people seeing their therapist from inside Walmart or Starbucks, but it happens. Obviously, McDonald's is a great one too. But we also see organizations collaborating with local businesses to say, can our patients park in your parking lot and use your Wi-Fi to see their provider? And that is happening a lot. Or organizations just saying, you know, cranking up their own Wi-Fi and saying, come park in our parking lot while the pandemic is raging, so you don't have to come in. So there's a lot of that going on, and obviously it's a lot of workarounds. There is no one right answer to that particular aspect of the question, like all the others. Technology platforms. Should we be using Zoom? Should we have an integrated system? Should we use this, that, and the other? We get lots of questions about that. There is no one right answer, but we emphasize flexibility. Find tools that do lots of things. Zoom has been huge, not only because it really has top-notch performance. It's like a Swiss Army knife for everything you do on live video. Soon, though, tools like Google Meet is also very integrated into the Google suite of tools. Microsoft Teams is doing the same thing. These are both systems that have HIPAA requirements built into the EULA, into the end user license agreement. So you click the box or you say, okay, when you start using Microsoft Teams or Microsoft Suite, you are already covered by HIPAA. I mean, not obviously HIPAA applies to covered entities and all of that, but you don't have to worry about security and such. Google and Microsoft have built that in. There are lots of other platforms too, and I can go into detail there, but there are lots of aspects. We just want people to make it a part of your everyday work. That's the ubiquity and the normalcy. The more you use video, the more you use audio. If you're using that, the more you use portals, the more normal it becomes for you and for your clients and patients. If for organizations that avoid it and say, yeah, boy, that was painful, we're only going to do that when the next pandemic hits, or when absolutely necessary, we'll dust off the video stuff and we'll let people see us, you know, from home. Every time you open it up, it's going to be a struggle then. Until it becomes normal, until we all get really comfortable with this, it's going to be a challenge. So we encourage people to use it as much as possible, integrate it as much as possible into your workflow. Professionalism, which is a kind of a big term for getting comfortable online. How do you frame yourself? How do you light yourself? How do you use your mute button? How do you make sure that you show up as a professional? It's true, you're sitting at home on your couch, but this is still a professional space. And you don't know how many people called me up and said, can you talk to my doctors? We're just not looking our best online. And yeah, we have to realize that there is a virtual space that exists. It exists cognitively, if not physically. And when you show up as a professional. Operations, this is a big area, but it includes everything from, you know, workflows and policies. And again, to underscore, we want this to be just another part of doing business. It may not be a big part for some. For others, it may be a very big part, but it needs to be a normal part, not a weird part, not an unusual part, not a second-class part, not like, boy, I wish you could see the doctor, but since you can't see the doctor, well, we got this telehealth thing, you might give that a try. I mean, that's a message that we're sending to people. It's like, you're not really being seen, you're doing telehealth. No, this is normal. This is high quality care. It's maybe not ideal. You'd like to be here. We'd love to have you here. But for now, we're going to do it this way. And we can provide good care this way. So there's a lot of messaging that goes into normalizing. Along with in operations, the whole area of, you know, emergency policies, recognizing that your 911 is not their 911 if they're not in your community. So you need to think and know where the patient is, know how to respond. Obviously you can't intervene, but you should at least not be caught off guard, flat-footed. What do I do? The patient's choking on a video call. What do I do? Don't be thinking about it then. You should have something in place ahead of time to know who you're going to call and what steps you're going to take so you can document that you took those steps. Obviously, you can't solve every problem, but at least to say, we have a policy, we followed the policy. that's your best defense. Self-care. This is going to be, you're going to hear more about this as we go forward. Early on, it was a big deal, but working online for an hour is not the same as working in the office for an hour. It is more intense. It's more blinkered. You got to have things, you got to take breaks, you got to move around, you got to get your butt out of the chair. It's just part of self-care that that people who are successful at this have learned to do. I do things like, I have a big window right here and I can look outside. So I can focus on the screen, but every now and then I can focus on a mile away if I need to. And that's nice just for my brain, for my eyes. To be able to do that is important. It also provides a lot of nice light as well. Not everybody has that option, but there are ways that we can work that help us sustain this kind of work. And then lastly, and I'll talk a little more about policies in the next slide, but we have a lot of policy flexibility right now. It's been a huge boon to the field and to telehealth. Those aren't going to all continue. The HIPAA enforcement relaxation right now is going to go away. We're going to have to use HIPAA compliant platforms. I mentioned a little about that already. Audio only is going to come under a lot of scrutiny. It will continue to come under scrutiny. You are likely to have a different federal rule than state rules in a lot of states about whether you can use audio and how you get paid for it. You already have differences in payers and how much they pay for that. We expect that to continue to be worked out. One of the things about audio only that we're realizing, in case this comes up, in the whole world of health equity, which is a big topic right now, research is showing that when we have less advantaged patients, and this makes a whole lot of sense when you think about it, when we have less advantaged patients and all of a sudden they can't come in, they are much more likely to use audio only telephone care than video care for the obvious reason. They don't have a laptop, they don't have an iPad, they don't have Wi-Fi, but they got a cell phone or they got a phone somehow. And so audio only access is becoming a health equity issue. Now, it's not obviously the best kind of care. We also have a lot of research, growing amount of research rather, that is saying it's better to be on video for lots of reasons than it is to be on a phone call alone. But it's better to be on a phone call than have nothing. So you know, we're moving people toward better healthcare as much as possible, but recognizing not everybody can access the highest quality care for whatever limitations there are, and we need to have flexibility. So that's where that is going. Controlled substances is another area that there was a lot of activity around. We got some flexibilities to prescribing substance abuse drugs like, well, methadone didn't get a lot of flexibility, but Suboxone and some others as far as in-person care and documentation. So that is probably going to go back to the way it was. There may be some development there, but it's not getting nearly the scrutiny that, you know, seeing the doctor from home, seeing, you know, doing direct to consumer, getting rid of geographic limitations and security online, and those other topics have gotten a lot more attention. All right, so those are my big six. One more slide, the future of telehealth policy. Medicare next year is going to be significantly different than it was 2 years ago. It's going to look a fair bit, at least in the mental health world, it's going to look a lot like it looked during the pandemic. We're going to get a lot of the flexibilities remaining in Medicare. Now, the audio only is not going to remain, but we are going to get seeing the patients at home. We're going to get a lot more providers able to bill Medicare. The new physician fee schedule has a lot of those changes sort of baked in. And the only change that that could be a restriction is that there is an in-person requirement once every 6 months, but it's not quite clear yet whether that's meant to mean behavioral health specifically or not behavioral health specifically, because it's talked about in two different parts of the regulation. We're still trying to get that sorted out and clarified. So anyway, stay tuned on that, but next year's physician fee schedule is going to, at least in the behavioral health world, show a lot of the flexibility that we've had during the pandemic. Medicaid, you're going to have new permanent rules in Wisconsin go into effect in January. They're going to kind of cement in a new billing process, which I think you've been using already. But audio only coverage is going to end. This is our understanding as of about a month ago, I guess. We still expect some regulatory activity between now and the end of the year. But we try and keep tabs on that. And I'd like to know a little more about what you guys are experiencing on the ground there in terms of billing and getting things paid for. Finally, I want to point out that we have you may not need all of this, but we've got some big billing guides on our website that we update every month. And right now we have updated them. Well, they've been updated every month for last year. We're in the process of contracting for them to be updated for the coming year, but they will be updated on a continual basis as these rules and policies change, and they cover all commercial payers in your state, or at least the vast majority of them. And they cover how to bill for telehealth, what services are available, et cetera. They also cover the medical side as well as behavioral health. So there's a lot of pages that you're not going to care about. But as you know, in the world of telehealth, we got to have this matrix where, what payer and what service and which payers are paying for what service and what codes are they asking for. Where we would love to see greater unity there, but not quite yet. So those are the big points that I wanted to make. If people want to talk more about workflows, if you want to talk more about clinical presentation, and when we talk more about possibly continuing this group, I have a few more slides that I can share. But for now, I will stop there and we will open it up for questions and discussion.
Dr. Neufeld, that's great. Really appreciate you, sort of kicking this off and talking about all the things that you can offer us. So, yeah, let's give him what he asked for. He's asking, what do you need help with? And do you have questions for him about some of this stuff? There's a lot changing, and we're just really excited to get you guys in touch with GPTrack and this organization so you can keep up to date on what's going on. What questions do you have for Dr. Neufeld? Challenges?
I guess just a comment. You had mentioned, Dr. Neufeld, about boots on the ground reimbursement for telehealth services and audio only. In our clinic, we have gotten the majority of telehealth visits reimbursed, including audio only, so that's been working well. It is interesting, and I think it's really helpful that you shared some of the changes to coverage in the legislature, things like that. So really, thank you for the resources.
John had brought up a specific, specific point that we were going to talk about some hybrid models too, and I didn't say much about that. I can make a couple comments just with regard to hybrid models, which is kind of shorthand for decisions around when do we do video, when do we do in person, all that going forward. We get asked that question a lot. And organizations think about that a lot. Most of the time people are thinking, are there recommended percentages? And the fact is no. It's sort of like, how much of your therapy clients should get cognitive behavioral therapy? How much should get behavioral, how many should be on an antidepressant? There are no set, this is obviously a case-by-case decision that gets made. You're going to have, some of you are going to work with clients that are much harder to reach. Some of you are going to work with clients that have lower levels of technological literacy or access. And so one of the things about telehealth that has made it so useful during the pandemic, obviously, is that it is a set of tools that go all the way from picking up the phone to live video to, portal-based access and images and all of that. And going forward, I'm crossing my fingers to hope some expert doesn't get into a big forum and say you should be having 25% of your cases be telemedicine, because it's a nonsense number. You need to use the tools to their best capability. Now, that said, here's some things that I do see happening with regard to that mix or a hybrid model. We have very often assumed that telehealth is kind of all or nothing, because the unit of measurement, the unit of accounting in healthcare is the encounter, right? And it's been for years, decades, been, the doctor and the patient go into a room, they have an encounter, they do something, and then they leave. And you bill and pay that unit. And so the temptation has always been, can telehealth replace in-person care? We're asking the question, can telehealth replace in-person care and everything about that encounter? And the fact is, no, it can't. There are lots of things you can do when you're together in the same room that you can't do over video. And so does that mean telehealth cannot replace in-person healthcare? What's going to be happening going forward is we're going to refactor that healthcare space in a lot of different ways. And the obvious fact is there are lots of parts of healthcare that we can do remotely, and there are some parts that we can't. You're never going to get your appendix out over video. It's just, it's just not going to happen. There are many things we're not going to do, but there are lots of things we can do, especially in the world of behavioral health. And so organizations are going to be redesigning care. Instead of being around encounter, it's going to be telephone call, video call. Okay, you need to come into the clinic this month. Okay, a video call this month. Okay, now a series of phone calls, and then shooting toward a goal, checking in with you. How's the response to the meds? How are you doing this week? Do we need to come in and see you this week? Is this call okay? Right? And we're going to be adapting as we go, using all levels of care. It's very similar to the levels of care models that we've looked at in the past, except we've got another whole set of levels below in-person appointment at the clinic, right? It was inpatient care, it was intensive outpatient, it was outpatient, and now we've got another whole set of levels, a video call, a telephone call, a portal check-in, a text message that you respond to. We've got lots of things down here that were kind of niche and rarely used in the past that now we have access to. So I think that's where we're going to see it going, and different types of practices are going to make use of these other levels of care in various ways. Any of you, I was just going to add, I'm a clinical psychologist by training. Any of you who have done therapy work, that just doing 2 or 3 hours of intensive work, there's a time for it, but you're not going to get the same impact as a half hour every week for 6 weeks, right? Behavior change takes time. And so I think what we as mental health folks are going to be experimenting with, we've got a lot more light touch options now that we didn't have before. And we have to get more efficient because there aren't enough of us to go around. And so we're going to see organizations really innovating in that space and thinking, okay, instead of an hour every other week, how about a half hour every week? Or how about a phone call every week with an hour session once a month or something? We're going to see that sort of thing.
So Dr. Neufeld, it seems to me that telehealth really would fit well into sort of these new value-based care models then, right?
It is. I think it's a natural fit. I think a lot of people are exploring that. Some of you may have heard there are insurance plans that are now virtual first, is what they're called, and the plan is, it's an insurance plan. You can choose it, and as a payer, they are going to say, we're going to give you all kinds of telehealth virtual care options. And we want you to explore virtual first. And then from time to time, you're going to have to come in and do an in-person thing. And obviously, if you go in the hospital, we're going to cover that. But for some patients, virtual first is a great selling point for a plan. And aside from just virtual first, your point really about pay for performance and paying for and quality-based care, there are lots of ways to use the tool. For years, I've kind of chided my colleagues because they say telehealth saves money. And I'm thinking, you know, it doesn't unless you make it save money, unless you set it up so that you're saving money with telehealth, because just using telehealth doesn't automatically save anybody any money, nor does it automatically improve access. We have to use it in a way to improve access. And I think what we're going to see is some providers are going to really lean into that and say, okay, we're going to figure out how to do this now that we have these tools. And others are going to say, well, that's kind of cool. My boss told me to check the box, and so I'm going to check the box. But it's going to take some innovation to get to the point where we are improving access, improving quality, improving cost and return, and all of those kinds of efficiency measures as well, and using that to contract for, you know, pay for performance kinds of things.
So let me get back to Fern. Fern, I think you had unmuted and had maybe a question or a comment for Dr. Neufeld.
Yeah, that was really good discussion right there as well. Good question. We provide a lot of in-home mental health treatment and community-based treatment. And so the question I was originally thinking of was what's happening, what's the potential, and what can we as providers and agencies do to advocate for access to telehealth resources, not just in rural communities, but sort of Wi-Fi dead zones in cities as well, or towns. We do certainly work with clients who don't have access to Wi-Fi. At the beginning of the pandemic, we were in on part of a grant to get tablets or Chromebooks for clients, and what we found was they didn't have the access, and therefore it was just too much trouble to use them. So we didn't have clients taking us up on that. So I guess that was my question then.
Yeah.
Do you want to respond to that?
Yeah, this has been, I think this isn't a silver lining at all. Maybe it's tin or brass, but one of the things that when all of a sudden everyone was thrust into the world of telehealth, and it's not that telehealth didn't exist before, it's just it wasn't on everybody's radar. Now it is on everybody's radar with the pandemic. And one of the things that it did is it took those pencil lines of the digital divide and drew them in black Sharpie. And it's like, now we see, okay, there's a huge divide. You hit a wall here, you fall off a cliff, and then there's nothing. And it's not just in rural areas, as you said, Fern. It's also in urban areas, and sometimes it's random, but sometimes, more often, it's sort of like, yeah, there are parts of town that have less access. There are communities that have less access. The whole equity issue has really exploded in the last year and a half. What can we do to change that? It is a complicated question. I'll just list a couple of different levels at which it's being addressed. Federal regulation, state regulation, it is a thing now, at least that's being talked about. The responses that we're getting, the usual responses, there is going to be, you're going to see millions and millions of dollars come through the FCC on the emergency broadband program. The EBB program is currently in the field. It's one. There, as we understand, there are going to continue to be millions, hundreds of millions of dollars going toward extending broadband. I think that's fine, but it's sort of like, well, I don't know what a good analogy is. A lot of that money just does not filter down to the Wi-Fi hotspot that your patient lives in for whatever reason. But it's good that it should be done. There are also federal programs that are now, and the EBB program is one that goes to directly subsidize patients' broadband costs. Now, there are a couple of reasons why that's challenge. On the one hand, not everybody needs $50 a month worth of Wi-Fi. What I need is, 1 hour a week. What and so you're going to be kind of overpaying for a service. And then on the other hand, we know many of our clients, it's keeping anything on a month-to-month basis and making that payment is just, it's a complicated process, right? Living the middle-class dream is a complicated process, is a hard process, is a difficult process. There are other challenges that predominate for many folks that we serve. And so there are going to be limitations to a program like the emergency broadband. What we're seeing at the local levels, unfortunately, I haven't heard much emphasis on this, but community-based broadband initiatives are popping up here and there. I'm just not hearing a lot of that. It doesn't make the news very often. But to the extent that your state doesn't outlaw those sorts of things, which some states do. Indiana, here we have a challenge. I live in Indiana, though I work for the University of Minnesota. And community-based broadband is basically non-existent. So because of regulatory hurdles, to the extent that states allow that sort of a thing, that can be a possibility. Like I said, cranking up the Wi-Fi access in and around office locations, or partnering with local businesses to provide, to cover their parking lot with Wi-Fi and allowing your patients to park there. Those are the kinds of creative things that we're seeing people doing, but it is a long way from, a commitment at the level of a state or a country to say, we're going to make sure every person has access to private, to publicly available and secure Wi-Fi. So sorry, long answer to what is to be been a frustrating question, but I am encouraged at least that there's attention being placed on it. It's on many more people's agendas and radars now. That is something we need to do, and it's going to be frustratingly, painfully slow to see that access grow. But I think I'm waiting for a business to come up with a broadband by the hour sort of a plan where hospitals or clinics can basically send you a link, and when you click that link, your cell phone logs in and you get broadband for an hour so you can see your doctor. So I don't have to keep it myself for a month at a time. I just get it as part of my login. But we haven't seen that product yet.
Sounds like you have a great idea there.
Yeah, I know. I'm thinking about patenting it, but yeah, we'll see.
So other questions from you all, things that you want to let him know, things you're challenged with or struggling with, or questions you have. Like I said, it's really a back and forth. Dr. Neufeld really wants to hear from us because he expressed to us when we talked to him that GP Track is really interested in the behavioral health area. It's something they want to develop more and they want to help out with more. So what can you tell him about challenges and questions that you're struggling with?
I have a challenge that I'll share that we have at our clinic, and then I also have a question. The challenge that we noticed throughout the pandemic is we have outpatient substance abuse from outpatient and IOP, and then we also have mental health programs as well. We noticed that our mental health programs did very, very well with telehealth. Our substance abuse folks, though, we had so many of them fall off, and they didn't have resources, or the phones that they did have were not capable to have the amount with Zoom to be able to log in with the other apps that they had on their phone. So that was one thing for sure that we noticed. The question I have is, as you're getting, as you say, the data is coming in, is there, how are you collecting the data? Are there certain surveys that you're using that you're getting these responses back from? How can we best help you?
That's a good question. Collecting information about telehealth is sort of a peripheral thing that we do. I happen to be, I started out as a health services researcher, and it's an interest of mine, has been for a long time. And so our TRC in particular takes the lead on a lot of data collection stuff. And so we have a broader range maybe than a lot of them, but we request data directly from Medicaid. We have public use data, scrub all the names out of there, all the identifying information out, and send us Medicaid data on telehealth. So we can see what's going on in the various states of our region. So that's one thing that we do. Sometimes with more success than others. Wisconsin is not a success yet, but we're working on it. Another thing we do is work with state governments directly and partner with them to, state officials often want to know, what's the experience of people in the field. And so we've called up, we did a partnership with North Dakota just a few months ago. They wanted to know what their behavioral health folks were doing. And we said, hey, we got some time, we got staff. Why don't we call? We'll call everybody and we'll do a little survey. And so we called about 100 organizations and did about a half-hour survey with each of them, compiled that into, and so that was information that the state board, the state regulatory agency, was the mental health regulatory agency, really wanted to have on who was using audio only versus other kinds of telehealth. We're in the process of doing the same thing in Minnesota now. More specifically, what are the technical assistance needs for the mental health community? So we do stuff like that. And then lastly, just forums like this. When I talk to people, the questions we're getting, the kinds of calls that we get, the kinds of information that people are asking for lets us know, what people need. But those are kind of the three levels of data, from very quantitative to very qualitative and individualized. One of the things, to the extent, one person calling up a regulator, calling up your mental health department, calling up your congressperson, that's not nothing. It's important. It's critical to do that. But also, if you have collective voices of various ways that you organize, whether it's a state mental health organization or state hospital association or whoever, and letting people know what you need, that's another. We just started a new cycle of funding, and we particularly, GPTRAC, are interested in developing many more, or at least more, sort of monthly, bi-monthly kinds of fora where people come together and talk about issues that they're facing, helping us keep a finger on the pulse in a little less formal but more direct, personal kind of way. Now that everybody's on Zoom, it's a little easier to say, hey, here's a Zoom link. Join us on Tuesdays at 4 o'clock, or whatever. In the past, it was always like pulling teeth to get people to do that, but people have become a little more used to it now.
So, Dr. Neufeld, how could our group connect with you and maybe just let you know how to get in touch with them, that type of thing, because anybody who's participating here today, I really want to encourage you to reach out to him. What would be the best way to just kind of let you know?
I think the best thing to do is, I'll put my contact info back up. Okay. Send me an email. I'll have one of our staff folks collect a list. We would be very happy to continue a forum a lot like this. And of course, I'm not trying to take over anything the MetaStar folks have done. I understand a fabulous job pulling this together. And as we were talking a couple weeks ago, it just kind of came up that this project was ending. And at the same time that we're thinking, hey, we're trying to find groups like this and organize groups like this, we would love to do that. And trust me, I won't be as monopolizing, and I won't talk the whole time. That's not the idea. I got plenty of other places to talk, but to foster conversation, do updates at whatever frequency is helpful, we can certainly do that. So send me an email, and within a week or two, we'll pull together a list or a group and just say, hey, what do you think? Is this some Tuesday afternoons at such and such a time, or when do you want to do this? And we're happy to do that. So reach out to us there. Those links are to our website and to the national website if you want to take a look at those resources, but send me an email directly there, and we'll get something like that happening. By the way, I wanted to mention that these slides, including a bunch that you didn't see that I mentioned that are optional in here, this is going to be emailed to everyone, I understand, after this meeting. So if you were wondering about that, that is on its way.
Yeah, and I want to encourage you all, because I know that some of you all are connected with county organizations and have maybe know other folks who've participated in, this particular grant. Reach out to your colleagues and let them know about GPTrack and Dr. Neufeld, and encourage them to send an email his way if they're interested in continuing to stay up to date with the telehealth changes. I think there's going to be a lot going on in this field, in this area, that's going to be clinically useful. So I can't think of a better place for you all to be connected than with GPTrack. And that's why we're so excited to have Dr. Neufeld today, because we really want to get you connected with the best resources possible. So
we also, I will just do one kind of shameless plug here. God willing, and the creek don't rise, we are having an in-person, we canceled our last 2 in-person conferences. We have one scheduled for May of 22 in Minneapolis. We try not to be Minnesota centric, but it just kind of is what it is, and it's central to our region. But at the Mall of America, Radisson Blue, very nice hotel there at the mall, we do an annual conference. And so May 23 to 25 of 22, we're doing our annual conference. We have, we'll see, in the past we've had 300 people. And we try and develop tracks. There's a community health center track. There is a large program track for the Alinas and Altrus and Marshfield clinics to talk about their programs. And then we often have a mental health track specifically for folks who are working in mental health. So we're just in the early stages of pulling that program together. If you send me your email address, or if you go to our website and post a question or something, you can tick the box of saying put me on your mailing list, and then you'll find out about that.
Great. Thanks a lot. We want to kind of tie things up here. So we have some resources, and Chris, I think there's just a few there that Dr. Neufeld even shared with us. So Lori, can you throw those up for us, and Chris will walk us through those?
Yeah. So first is, obviously a link to the Great Plains Health Resource and Assistance Center there, link to that. Another great resource, the National Consortium of Telehealth Resource Centers, Center for Connected Health Policy, and then the URSA Telehealth website. All would highly recommend taking a look at all those, and we'll also include those in the notes that go out after the meeting too. So
yeah, great, thanks. As I said, some of those were recommended by Dr. Neufeld when we spoke with him, and we always try to provide you with the sort of national and best resources that we can come up with. So all right, by way of ending up today, I just really want to thank everybody for coming. I want to encourage you to sort of talk about this with colleagues, in the behavioral health community, other, county clinicians and clinics that you're familiar with. Reach out to those people you contract with. But really appreciate y'all's participation throughout the 6 sessions that we've had. And I want to remind you to continue working on your IT goals. I think it was one of the things that we did was at least help you be aware of what was going on and what you maybe needed to keep working on. And we're going to try and do that with our last 2 podcasts to help you focus on what to keep your eyes open for. So thanks again, Dr. Neufeld. We really appreciate you coming today. Excellent, really excellent, sort of presentation and discussion. I think there's a lot to be talked about in the future, so hopefully we'll get folks in Wisconsin connected with you in a better way. All right.
Great. Yep.
Thanks so much, everybody. Appreciate you coming. Y'all take care. Have a great day, and don't forget to reach out to Dr. Neufeld.